about 1 in 5 patients will require non-cardiac surgery within 2 years of stenting. Now, that kind of puts them at high risk, particularly the earlier it is after the surgery because of the risk of bleeding. So we're here talking about a December 30th, 2014 issue of JACC, and we're looking at, there's an original paper on the incremental risk of non-cardiac surgery on adverse cardiac events following coronary stenting, and I am with the author of the editorial comment, Patients with Coronary Stents Need Surgery, What Do We Do? And I am with Dr. Emmanouil Brilakis, MD, PhD, Director of the Cardiac Cath Laboratories at the VA North Texas Healthcare System and an Associate Professor of Medicine at the University of Texas Southwestern Medical Center. This was an interesting piece because I never realized that it was going to be such a long period of time that there was still going to be risk. That was kind of a surprise to me. Was it to you?
Well, so you're right. You would expect that the stents are put in and the patients would be okay after a while, but actually it's not, because we had several patients who, even a few years after they had a stent, they get a surgery and they come back to the cath lab in cardiogenic shock because the stent blocks up. So although they're not very common, we do see these patients who don't do very well and get very late stent thrombosis.
So in this paper, what did they look at specifically?
So this is a very important paper. It comes from a large VA database with more than 40,000 patients who got stents. So what they try to look at this particular sub-analysis is how does timing after stent implantation matter? So how high is the risk early on? How high is the risk later on? And they divided the period of time into 3 time periods. The first one is the first 6 weeks, which we know from older studies that this is the highest risk period for stents to close, and then 6 weeks to 6 months, and then from 6 months on up to 2 years. So what they found is that in the very early time, which is the first 6 weeks after stents, it's about 3% absolute increase. So 1 in about 36 patients, it's going to have a major event, death or myocardial infarction, if surgery happens within this early window of time. Then that goes down to 2% in the 6 weeks to 6 months. And then when we go from 6 months on, it's still an absolute 1% incremental risk. So 1 in 100 patients is going to have an adverse event just because of the fact he had a stent placed in him a few months or a few years earlier on.
Did it matter whether it was a bare metal stent or a drug-eluting stent?
It did not, so the risk was for both. But interestingly enough, bare metal had even higher risk than drug-eluting stents. And that may not be the drug-eluting stent fault, but maybe partially, if the patient is very sick or has comorbidities, we tend to put bare metal stents more often than drug-eluting stents. But it was true for both kinds of stents, and actually bare metal was even worse.
Now, what were the comments you made in your editorial comment regarding this paper?
So it's something that is very practical. So in my practice, I would say a third of the questions I get on a daily basis are on this topic. The patient has stents, needs to go for surgery. What do we do? We made guidelines locally, and in spite of that, everyone gets confused, everyone gets nervous, the surgeons get nervous, anesthesia get nervous, the referring internal medicine physicians or surgeons get nervous, so everyone is nervous about this. So it's something that is on everyone's mind. So I think it's something important to know. In my mind, the main lessons from this is that if you have a stent and you go for surgery, you have to be aware that there's a risk there. There's a risk for stent thrombosis, of dying, having myocardial infarction, so we should be more careful about those patients. And one easy thing we can do, and all be thinking about, is don't do surgeries in facilities without an on-site cath lab, because in the rare event where you have a stent thrombosis, for example, you want to be able to treat it as soon as possible, and the best way to treat those is doing primary PCI, because thrombolytics obviously is not the best approach after you had a recent surgery, especially a major surgery. So one message is always be aware of the risk of the patients who have previous stents. When they go for surgery, even years down the line, they can still develop a complication.
If you know a patient has non-cardiac surgery scheduled in the future, do you handle it differently?
That's an excellent point. So yes, the answer is yes. If you know you're going to have surgery, then the first question is, do you really need a stent?
Right now, this instant.
In this, because if it's something, the patient is stable, doesn't have high risk, he can exercise, go up a flight of stairs, doesn't have significant symptoms, then you can, in most cases, go for your operation, and then once you are done with that, then come back and then you can have your stent or any other revascularization form. So in those cases, it's easy, we can just wait and do it later on. Where it becomes more challenging is, for example, in an acute coronary syndrome. Patient comes in with a non-ST elevation MI or unstable angina and they really need something done. Then the question is, how do we revascularize them? If we know they need a major surgery, then sometimes bypass, if indicated on the clinical grounds, may be the better option. Because if you have bypass, then you don't have the risk of stent thrombosis or other major events related to stent, that's a great option for these patients. If you are not a candidate for bypass, then that's a different story. And for those patients, the options are either do balloon angioplasty only, have some early data saying balloon only, after 2 weeks you're okay risk of going for surgery. You may restenosis, but then by the time you restenosis, you'll be off the window of surgery and do the stent at that time. If you put a stent, then ideally put a bare metal stent, although that's debated as well because we now know the newer drug-eluting stents have very low risk of stent thrombosis. So maybe even in those cases, drug-eluting newer generation, especially the everolimus-eluting one, might be an option for those patients. But in general, the current standard of care is put a bare metal stent if you know the patient needs surgery within the first year after the stent is placed.
So I think Holcomb et al. Have written a fairly important paper here, wouldn't you say?
Absolutely.
That this is something that we need to think about a little bit more in practice.
Absolutely. I think it's very in line with the DAPT trial results, because even DAPT just presented in this meeting shows that even up to 2.5 years after the stent is placed, the risk continues and is not insignificant. And imagine if the risk is there regardless of surgery. When you have surgery and the body has the prothrombotic milieu and there is a more risk of getting stent thrombosis, that's even more so in this particular setting.
Well, 6 weeks, I certainly was aware of that. 6 months, I could understand, but it was kind of a surprise to see 2 years and still an elevated risk of MACE.
That's true. But again, it's not just, I think it's not just the stent itself and the healing process. It also has to do, as discussed before, that we have also the surgery, which the body is trying to clot off and stop the bleeding from the areas that are injured on intention during surgery. So it's a combination of having something. Inflammation. Exactly, inflammation, the prothrombotic state induced by surgery, and some material metal in the coronary that may cause the problem. Now, in the future, with absorbable stents, potentially 2 or 3 years later, there might not be as much of an issue if the stent resorbs, or maybe stents with absorbable polymer might be another appealing option for these patients. But for now, I think many people feel comfortable with the bare metal stents.
Well, this pair of papers is in the December 30th issue of JACC. It's the original paper by Holcomb et al. And the commentary by Dr. Brilakis. The December 30th, 2014 JACC for CardioSource World News. I'm Executive Editor Rick McGuire.